Hello, and thank you for joining us for the 49th Annual AAKP National Patient Meeting. We hope you have enjoyed the sessions thus far. My name is Dammeon Marshall, and I am a chronic kidney disease patient from Atlanta, Georgia. I'm honored to serve as your AAKP Ambassador. This role has inspired me to deepen my knowledge, share all of the information that I have learned with everyone I meet, and live a life of purpose and fulfillment. As a social worker, I witnessed the full spectrum of human experiences, the good, the bad, the ugly, and the indifferent. Each of these encounters, no matter how challenging, has strengthened my foundation, guiding me to walk confidently in my life's purpose. As a proud AAKP member, I firmly believe that every kidney patient's voice is paramount in determining their care plan. It is essential that we cultivate an environment that encourages kidney disease research and innovation, driving continuous advancements in care, improved treatment, and solutions for unmet patients' needs. Once these innovations receive FDA approval, it is equally important that all patients have access to get and the right to choose the best treatment for them in consultations with their healthcare team. This ensures every patient can live their best life and achieve their aspirations. With that, it is my honor to introduce our next session, titled Innovation and Research, Trauma Donor Organs, an Alternative Source to Eliminate the Organs Shortage. The severe organ shortage remains a critical challenge for kidney patients and others awaiting life-saving transplants. At AAKP, we believe that exploring innovation solutions such as using trauma donor organs, like we will hear more about today, is essential for expanding the pool of available organs and offering new hope to those on waiting lists. This session will be led by Dr. Frederick Gage, CEO of the Ischemic Injured Organs and Limbs Foundation. Dr. Gage pioneering research into the potential of ischemic injured organs as a valuable source for transplantation represents a significant advancement in the field. His work has the potential to increase organs availability and improve outcomes for patients who may otherwise face prolonged waiting times. Understanding and supporting innovation like this is crucial for kidney patients, as it directly impacts access for life-saving treatments. We are excited to have Dr. Gage share his insight and research with us on today. Please join me in welcoming Dr. Frederick Gage.
Thank you very much, Dr. Marshall, for the introduction. I'd like to thank the American Association of Kidney Patients so that I can talk about trauma donor organs, an alternative source to eliminate the organ shortage. I do hold a trade secret to the room temperature organ preservation solution. So I can add a little bit more to my background. I attended The Ohio State University, and my undergraduate study was in the field of circulation technology, which basically is to run the open heart equipment. I also worked at the University Medical Center in the biomedical department. So every morning at 5 o'clock, I would come in and start the central dialysis station to stabilize the dialysate. For you all who are not familiar with the central dialysis station, it has 12 to 25 different stations so that you can dialyze each individual on their own station, but have a central dialysate pump. When I graduated from the Ohio State University, I was very fortunate to be hired by the Ohio State Medical Center Department of Surgery with a 50-50 split, 50% clinical, 50% in research. Some of the projects that I did, I worked with neurosurgery, obstetric gynecology, anesthesia, ophthalmology, developing procedures with lasers. At the same time, I worked with the cardiothoracic teams, developing artificial hearts, developing organ heart preservation system. But my favorite was always transplant. I was fortunate to help out with self-sealing dialysis grafts, help out with development of room temperature liver preservation. And in 1985, we started developing xenotransplant grafts using a pig to a dog model with the long-range goal of going to human transplants. This is all before the 1984 Transplant Act. The 1984 Transplant Act was very important because it merged the independent organ procurement organizations that was with each transplant center into a regional organ procurement organization. Let me give you an example. In Washington, D.C., there were 7 transplant centers along with their own OPOs, or organ procurement organizations. And what happened was it was very confusing on where do you refer an organ donor to. The disadvantage of the 1984 Transplant Act was that it eliminated the personnel and the funding for a lot of the universities to continue their clinical research, because the staff members who would go out and do the recoveries and work behind the scenes with the organ procurement organization now became part of the organ procurement organization because the transplant centers did not have funding. I was fortunate that the Ohio State University had a very large endowment in the Department of Surgery. Einstein is credited with saying, insanity is doing the same thing over and over again, expecting different results. The regional organ procurement organizations, the United Network for Organ Sharing, and the Organ Procurement Transplant Network has continued this model since the 1984 Transplant Act. They continue to say that, well, we're going to increase organ donation, and you will see later in some of my slides that it's almost impossible for them to get more donors, except for transplant programs are very initiative. And they developed what is known as the Living Donor Program, where they share organs around the United States in case there is not a match. However, the federal government started a brand new Transplant Act that became law in September 2023, and effective as of August 29th, 2024, the new Organ Procurement Transplant Board is made up by the American Institute for Research, who is going to oversee this. End-stage organ failure, or ESOF, as you can see, the Center for Disease Control has looked at the number of patients who have been diagnosed with end-stage organ failure. And they've gone a little bit farther, and they've said that 10% of those people who have developed end-stage organ failure will need a transplant sometime in their life. And as you can see, effective as of September 1st, 2024, there's only 114,264 patients on the national waiting list. Now, in order to get on the national waiting list, there are some very strict criteria. UNOS and the organ procurement organizations and the Organ Procurement Transplant Network has put in some very strict laws that limits who can be on the national waiting list. And of those 114,264 on the national waiting list who are waiting for an organ, only approximately 25% of those people will ever receive a transplant. What is a trauma donor organ? So when somebody comes into the trauma unit and they pass away after all attempts to save their lives and they are pronounced cardiac dead, they are a potential organ donor. Causes for trauma death: vehicular accidents, cars, trucks, motorcycle, boats, bicycles, industrial accidents, factories, farming, construction work, acts of violence, guns, knives, fights, overdose, drug overdoses, suicides. And when the family decides to donate these organs for transplant, those organ donors are referred to as donation after cardiac death. Trauma donor history. Cardiac death was the primary determination of death up until the mid-1980s, when cessation of brain activity or brain death became the standard of care in the field of transplantation to determine when an individual died. From 1990 to the year 2000, Washington, D.C. was the murder capital of the world, with an average of 600 homicides each year during that time frame. Washington Hospital Center was the major trauma center and transplant center during that time period. Washington Hospital Center performed a death audit looking at every trauma death that came into their trauma center. And they discovered in the year 1992 that they had a potential trauma donor every other day. So in 1993, when I arrived at Washington Hospital Center, I had two objectives. One, to develop the equipment to preserve the organs inside the body. And number two, to write the procedures to operate that equipment. In 1994, we initiated a human clinical trial on every trauma death where the family members were present, asking permission to preserve the organs inside the body so the next of kin could decide whether to donate the organs for transplantation. In 1995, we amended that protocol so that every trauma death that came into our trauma center at Washington Hospital Center was a potential organ donor. We preserved the organs inside the body. Part of that research protocol was we had to follow up with the families a couple weeks after the person's loved one has passed away, finding out what they thought of us preserving the organs inside the body. Whether the family donated the organs or whether the family declined to donate the organs, every family, they were very thankful that they had the opportunity to consider organ donation. In 1996, President Clinton signed into law allowing us to preserve organs inside the body. The American Bar Association, they heard about our rapid organ recovery program. They came out and evaluated what we did, and they wrote in their journal Litigation, volume 24, issue number 4, the summer of 1998, that rapid organ recovery program is ethical, moral, and legal. It allows the family of the victim to donate the organs for transplant so that something positive can come out of this tragic situation. The 1996 federal law, it allows for the preservation of organs inside the body while the next of kin is found and consent is given for organ donation. It allows for us to make a small incision in the upper part of the leg and put catheters into the artery and vein and to continuously run an organ preservation solution, whether it is blood or synthetic solution, to preserve the organs inside the body and resuscitate or revive those organs so that they become viable for transplant. It allows us to start the organ preservation procedure up to 4 hours after the heart has stopped and the patient has been declared dead. It allows us to preserve the organs and revive the organs inside the body up to 8 hours after we begin this procedure. The rapid organ recovery results after the 1996 federal law went into effect. We only recovered kidneys, livers, and pancreas, or pancreata for plural, while we were preserving the organs inside the body. And the reason was there were no equipment available to preserve the heart and the lungs after they were recovered. It allowed us to increase the total body organ preservation from an average of 2 per week to an average of 5 per week. Our consent rate for organ donation went from 1 per month up to a total of 5 per month. The survival rate of the kidneys at 1 year, 95% of those kidneys were still functioning and 100% of the patients were still alive. At 5 years, 90% of those kidneys were still functioning and 97% of the patients were still alive. I'm going to not include the results of the liver and the pancreas right now because of the length of time on my talk, but we can go over that in the question and answer period later. Our cardio emulating organ resuscitation equipment. As you can see there in the left-hand upper corner, there is a 20-inch carry-on case that is our final prototype design. Our system allows us to have an artificial heart, and you can see the pulse rate and the pressure waveform there that we duplicate with our heart. We also have an artificial lung that allows us to preserve the organs inside the body and while we're transporting the organs. It's the same equipment modified for different uses. We use sensors to evaluate the chemistry of the preservation solution so that we can immediately make corrections to the solution so we are reviving the organs inside the body or after they've been recovered so that they become viable for transplant. We have a built-in filter purification system that inactivates the microorganisms and viruses so we can reduce the amount of antibiotics used on each patient. In our transport system, we have a built-in tracking mechanism along with data transmitter that we send the data and the location of the organs to the transplanting hospital so that the transplant team knows where the organs are at all times. When we get the organs to the regional preservation lab, we will put the organs into our scanner so we can continue to evaluate the chemicals of the perfusate or the chemistries of the perfusate. At the same time, we are taking digital imaging of the organs so the transplant team not only has real-time perfusion data, the transplant team also has digital images of the organs. So we do not have to take biopsies. They see the whole organ and the vascular structure. It's like a mini CAT scan. We use our proprietary algorithm that predicts the viability of the organ, and the predictability is 99.5% accurate. It will tell us whether the organs are going to function immediately, whether they're going to have some delay function, or there's going to be primary non-function. If the organs function immediately, we will schedule a time with the transplant team to transport the organs up to the transplant center. And we will then, if there's delayed graft function, we will rely on the transplant team to tell us whether they want to accept the organs or not. And if it's a primary non-functioning organ, we will either discard the organs humanely, but if we have consent from the family for research, we will use these organs for research. We are currently in the final stage of designing our clinical machine so that we can start FDA clinical trials in the near future. We have the machine there that you see is designed for the heart, the kidney, the pancreas, the intestines, and amputated arms and legs. We use a machine that's about 1.5 times the size of that, or about the size of a 30-inch carry-on suitcase for the liver and for the lungs. When I was in college, one of the courses I took was to evaluate, and it was an evaluation course to improve productivity. Using the state-of-the-art practice and works effectively, I was taught to evaluate the procedures that was going on and can we improve what we're doing? If not, we'll continue doing the same. If we can improve and increase the viability or increase the results, then we change. The Healthcare Cost and Utilization Project, which began in 2012, evaluates every in-hospital death in all the hospitals throughout the United States. The mean average of brain death throughout the United States is 17,434 individuals die with brain death each year. The average number of cardiac deaths at a hospital is 822,489 for a total in-hospital death each year in the United States. And this is an average, 836,923. Now, if you ask me, Fred, these are large numbers. Why can't we use all these cardiac dead donors? Well, a lot of those patients have active cancer. They have active infections and other comorbidities that does not allow us to transplant those organs into humans. However, we've looked at the American College of Surgeons, along with the Center for Disease Control. They collaborated together, looking at the average number of trauma deaths a year. So since the year 2000, their average is 225 trauma deaths a year. The average overdose death since 2019 is 107,000 a year. The average suicide rate is 38,992 per year. I am sorry if I sound morbid. I don't mean to be, but these statistics are very tragic. And I have been taught in the field of transplantation that every time you allow a family to donate an organ, that family has something positive happen from a tragic situation. I know that a lot of you here today are waiting for an organ transplant, and I understand exactly how you feel. In the year Thanksgiving 2012, my sister called me and said, Freddie, I just got diagnosed with kidney failure. Can you help me out? So being a good big brother, I picked up the phone. I called the University of Michigan and talked to the chief of transplant, who's a very good friend of mine. And I said, would you please evaluate my sister for a kidney transplant? He said, sure. Can she get down here by 8 o'clock tomorrow morning? So I called my sister and my brother-in-law and my mom. They went down to the University of Michigan. My family lives approximately about 3.5 hours north of the University of Michigan. They were evaluating her, so I walked into my chief where I worked. I worked at the Army Navy Transplant Center in Walter Reed and talked to the colonel and said, hey, I'm going to donate my kidney to my sister. Would you work me up and evaluate me? They sent all my data up to the University of Michigan, and I passed with flying colors. But my sister and I did not have a match. So talking to the University of Michigan, they put my sister on a share list so that they could swap out kidneys with somebody who matched my sister, and I would donate to somebody who matched me. Tell you this story because it drives me to develop this program that we're talking about now. The Center for Medicare and Medicaid Services has approved the Ischemic Injured Organ and Limb Foundation as an alternative organ procurement organization specializing in the recovery of organs from cardiac death, trauma, overdose, and suicide victims. Once we have sufficient funding, we will finish our design and building of our clinical organ preservation systems. We anticipate to have our clinical study started the end of the year 2025, the beginning of the year 2026. Once we have the equipment approved by the FDA and we have set everything up and we've trained enough staff members to start recovering organs from the 36 trauma centers in DC, Maryland, and Virginia, or the DMV region as it's referred to. We will also transplant those organs at the 12 transplant centers within the DMV region, along with following UNOS guidelines where we share those organs with somebody who matches those organs within a 250 nautical miles of Washington, D.C. One of the things that we are going to do with every patient that is in the DMV region waiting for a kidney, we're going to offer them the opportunity to receive an organ from a trauma victim, but they have to sign a consent before we start this program or when they first come onto this program so that we can more rapidly place the organs and get the organs transplanted within a very reasonable time. As you can see, we anticipate once we start this program that we'll be able to recover 1,524 organs from trauma victims, overdose victims, and suicide victims. As we train more staff and we open up more of the trauma centers, the level 1, level 2, and level 3 trauma centers within the DMV region, we should, by the end of 5 years, be at all 36 trauma centers and be able to recover a minimum of 2,532 organs from trauma victims. As we train more staff and we expand across the United States, we will start off recovering trauma donor organs at the 200 level 1 trauma centers throughout the United States. And as we train more and more staff, we expect to expand to level 2 and level 3 trauma centers also. You can see our first year, we are anticipating where we will recover 55,000 trauma donors a year. And in that trauma donors, I include overdose and suicides. As you can see, over the next 5 years, we anticipate increasing the number of trauma donors to 104,362 over those 5 years. As you can see on the bottom there, that the living donors and the brain dead donors are staying consistent. And if you go back to the hiccup study, you can see that there's approximately between 17,000 and 18,000 brain dead donors a year. Thank you very much, ladies and gentlemen, for allowing me to share my talk. And I would really like it if you would ask some questions so that I can give you some answers more in depth.
Dr. Gage, thank you for an incredible presentation. I would like to ask you a few questions before we let you go. Our first question is, what are the main biological and clinical challenges that currently limit kidney allograft survival?
The shortage of organs. Actually, besides the shortage of organs, patients being compliant with their immunosuppressants and following what their transplant team tells them to do. That is probably the one thing that can lead to longevity of kidneys that are transplanted.
My next question, how has your understanding of how the immune system reacts to kidney transplant evolved? And in what ways is this information being used in your work?
When I started transplants back in the 1980s, you basically had steroids and Imuran as the immunosuppressants. And then cyclosporin came. And then you came with FK506. And now you're getting into the use of genetic markers and designing immunosuppressants that are more in tune with the individuals. I think where things will go with immunosuppressants in the future, we will be able to fine tune those immunosuppressants so that they will be more tuned to the individual than to the masses the way we're doing things now.
My final question, how has the voices of patients and their unmet needs inform your work and fuel your desire to improve transplantation?
As I told you about my sister and a lot of the patients that I've met in dialysis centers, there are patients that want to be transplanted. And there's stories that I could go on and on and on about if we only had an organ. My grandparents taught me on the farm that nothing is impossible, you just have to find a solution. I am disheartened by the way we have treated dialysis patients and other patients that need organs for transplant by saying you have to jump through these very strict hoops in order to become a potential recipient of an organ. We need to develop more organs for transplants, whether it's trauma donor organs, whether it's xenograft organs, pig to human transplants, or whether it's 3D printed organs and using stem cells. We need to find the time to develop research protocols and methods to increase the organs so that those 8,790,000 people who will need a transplant will get a transplant. We need to start following what's going on in Europe and Canada so that we start transplanting patients when they're stage 2 and stage 3 organ failure before they're stage 4 and stage 5, because we know from the studies done in Europe and in Canada that those organs survive longer when the patients are more healthy when they get a transplant. Thank you very much.
Thank you, Dr. Gage. I know your shared insight and expertise has truly resonated with our audience. We are grateful for the time and effort you put into joining us and delivering such a valuable presentation.